continuing with the topic. Now we are proceeding further to intrauterine death or IUD. Okay, if they say about the Robert sign, that is first sign of intrauterine death that we see, that is the presence of the gas in the great vessels in the fetus, and it becomes positive within 12 to 24 hours after the fetal death. Second sign we see is a Spalding sign, that is overlapping of the cranial bones of the fetus and becomes positive within a week of the fetal death. And third sign is a ball sign, which is a hyperflexion and hyperextension of the fetal spine. Okay, so these are the as a gynecologist, if a lady is coming to me and asking that I'm not able to feel my baby moving inside my womb since 1 or 2 days, and I look for the fetal heart and I'm not able to hear any sound, so I will go for ultrasound, and in ultrasound I will find 3 signs. That is, first sign is the Robert sign, which is within 12 to 24 hours of the death, that is the presence of gas within the great vessel. Second sign I will found is known as Spalding sign, Robert sign, Spalding sign, and ball sign. Robert, Spalding, and ball. Robert, Spalding, and ball. Robert is presence of gas in the great vessels, and Spalding is overcrowding of the bones, and ball sign is hyperflexion and hyperextension of the spine, right? Then if we are talking about what about the neonatal complication in the diabetes, like once a baby is born, do we have any kind of complication to the baby which is born to a diabetic mother? Of course there are, right? There could be a respiratory distress syndrome because of the increase in insulin, there is less surfactant which is produced inside the body of the baby, and that could lead to premature respiratory distress syndrome. It could also lead to hypoglycemia, which is less than 4 mg per deciliter, which is life threatening. It could also lead to decrease in potassium, calcium, and magnesium. There is hyperviscosity syndrome, like polycythemia and hyperbilirubinemia. So it could also lead to decrease in potassium, calcium, and magnesium. Both lead or can also lead to hyperviscosity syndrome. What is hyperviscosity syndrome? There is polycythemia along with hyperbilirubinemia. That means hyperviscosity syndrome, the polycythemia. RBCs are also increasing, and bilirubin is also increasing, and there is hyperviscosity of the blood. So this is because of the neonate which is born to a diabetic mother. These are the complications. So I am revising. If we are talking about any anemia that would be in the patient, no, it won't be any anemia. It would be having polycythemia. And if we are talking about any mental retardation, no. And if we are talking about like the baby's born, right? So they are saying that it could have premature respiratory distress syndrome. I know that as a gynecologist this could happen, so I would need to check. I will need the best test I should do for assessing the lung maturity in females of diabetic mother is phosphatidylcholesterol, in which if present in the amniotic fluid, lungs are mature, but if it's not present in the amniotic fluid, then lungs are not mature. Can we detect the lung maturity? By the best test is detecting it in the amniotic fluid, and if phosphatidylglycerol is present in the amniotic fluid, that means lung is mature, and if it is not present, that means lung is not mature. Phosphatidylglycerol is one of the important signs indicating the maturity of the lungs. If we talk about the tocolytics are contraindicated in diabetic mother. ठीक है. Beta agonists like ritrodrine or isoxaprine or terbutaline or salbutamol. If you are talking about the tocolytics are contraindicated in a diabetic mother, and if you are talking about the beta agonists can also lead to hyperglycemia. Okay, and if you have to give a tocolyt, then tocolyt of choice in a diabetic mother is nifedipine. Although tocolytics are contraindicated in diabetic mother. Okay. So let's just revise the topic. In intrauterine death, will have three signs, that is robot, gas were present in the bladder vessels, and second sign would be the Spalding sign, where is overcrowding of the bones, and the third sign would be the ball sign, where hyperextension and flexion of the hyperextension and hyperflexion of the fetal spine can be seen. And then we had what are the complications that come in a neonatal due to a diabetic mother. So as a neonate is born, due to increase in insulin, there will be decrease in the surfactants, so they could lead to respiratory distress syndrome. Second, it could also lead to hypoglycemia, that is less than 40 mg per deciliter. It could also lead to less potassium, calcium and magnesium. It could lead to, okay, 4 points were there. First I have said, and second sodium, potassium, calcium. Third, it could lead to hypoglycemia. It could be life-threatening, less than 40. And fourth, it could also result in hyperviscosity syndrome. What is hyperviscosity syndrome? There will be polycythemia, that means RBCs would increase in number, and there would be hyperbilirubinemia, bilirubin would also increase. And if you are talking about any anemia or any kind of mental retardation, no, it won't be there. If you need to check about whether the lung is mature or not mature, which of the following tests will do? You can go for phosphatidyl glycerol in the amniotic fluid. If it is present, then yes, the lungs are mature. If absent, lungs are not mature. And tocolytic of choice is nifedipine, otherwise they are tocolytics are contraindicated. And beta agonists are also not given, it leads to hyperglycemia. So let's do some MCQs of this topic. इमली मुझे ये तो बता दे कि फास्टिंग ब्लड शुगर लेवल वाला वो बताओ, पर ये नहीं बताया कौन सा वाला। इसमें इस बुक में तो 3-4 मेथड लिखे हुए, मुझे क्या पता मैंने कौन सा मेथड अप्लाई करना है। या तो बता दो कि ACOG वाला करना है या WHO वाला करना है या फिर इंडियन मेथड फॉलो करना है। ओवर डायबिटीज़ उसमें कहते हैं जिसमें फास्टिंग ब्लड शुगर लेवल मोर देन 126 हो, जिसमें रैंडम ब्लड शुगर लेवल मोर देन 200 हो, और जिसमें HbA1c 6.5 हो, HbA1c 6.5 हो, फास्टिंग ब्लड शुगर लेवल मोर देन 126 हो, एंड रैंडम ब्लड शुगर मोर देन 200, रैंडम ब्लड शुगर मोर देन 200, रैंडम ब्लड शुगर मोर देन 200, fasting blood sugar more than 126 and HbA1c more than 6.5. वन स्टेप प्रोसीजर तो WHO वाला ही है। यार ऊपर ना लिखा है कि वन स्टेप प्रोसीजर फॉर जेस्टेशनल डायबिटीज स्क्रीनिंग, और नीचे MCQs में डायग्नोस्टिक लिख रहे हैं। स्क्रीनिंग है ये, डायग्नोस्टिक नहीं है। वन स्टेप प्रोसीजर इज 75 ग्लूकोज ओवरनाइट फॉर 2 hours। तो ये WHO वाला मेथड है। वन आवर है किसी में, चेक करो। मेरे अकॉर्डिंग सब में 2 आ रही है। जो पहला 2 स्टेप मेथड है उसमें हमने 2 घंटे के बाद चेक करना है। जो दूसरा है उसमें 1 घंटा, 2 घंटा, 3 घंटा। उसके बाद जो सिंगल स्टेप है उसमें 2 घंटे बाद, उसके बाद जो सिंपल स्टेप है 2 घंटे बाद। इतने सारे मेथड बता दिए इसने, तब भी मेरा फाइनल वाइवा में मुझे कुछ चंबड़ कर दिया था। ये भी 2 घंटे का है, इसमें 3 घंटा है। जो फर्स्ट टेस्ट है उसका स्क्रीनिंग वाला वो 1 घंटे के बाद है। सबसे पहला है वो 1 घंटे के बाद है। यार पर ये बहुत कंफ्यूजन है। 2 स्टेप, 1 स्टेप और ये डिप्सी क्राइटेरिया जो इंडिया में फॉलो होता है। अब जब क्वेश्चन में या तो फिर एग्जैक्टली पूछो 1 स्टेप प्रोसीजर मतलब WHO वाला, 1 स्टेप मतलब WHO वाला, 75 ग्राम 2 hour, ठीक है। minute 28 because it started when what should be the fasting blood glucose target in her? लेस देन 90 लग रहा है मुझे। गाइनोकोलॉजिस्ट उसकी नॉर्मल वैल्यू फास्टिंग होती है 70 to 95 जेस्टेशनल डायबिटीज़। तो अगर मुझे उसको ठीक करना है तो मेरा गोल होना चाहिए कि फास्टिंग के बाद उसकी 70 to 95 होनी चाहिए, और 1 आवर पोस्ट प्रेंडियल उसकी लेस देन 140 2 और 120 होनी चाहिए, और उसका HbA1c लेस देन 6.5 होना चाहिए। और ये सब कुछ 2 हफ्ते के अंदर होना चाहिए। अगर नहीं हुआ तो इंसुलिन पर डाल दें। नाइस, समझ ठीक है। अकॉर्डिंग टू Priscilia, white classification of diabetes in pregnancy, all of the following classes should be managed by insulin except class A1. During pregnancy. Okay, so they are telling that for hyperglycemia, why are we not giving metformin and why are we giving insulin? Insulin given because it is the preferred treatment and it does not cross the placenta. Whereas if we give the metformin, it will cross the placenta, although it is not heterogenic to the fetus, but it's just that we are giving insulin that should be working within the mother only, na? Because mother is diabetic, so why are we giving a drug which is crossing the placenta? So drug of choice here is insulin. जो मेटफॉर्मिन है वो हमें पता लग गया कि वो प्लेसेंटा को जो क्या करती है, क्रॉस कर जाती है, इसलिए हमको नहीं देते। ऑल्दो उसका कोई टेट्रोजन इफेक्ट नहीं है, बट जो सी इंसुलिन है वो जो सी होती है वो क्रॉस नहीं करती, इसलिए उसको देते हैं। दूसरी चीज़ है ये है कि डाइट कंट्रोल जो सी फर्स्ट मैनेजमेंट है, ठीक है। उसके बाद फार्माकोलॉजिकल अगर एजेंट कोई देना है तो हम इंसुलिन देंगे, और क्योंकि हमें चेक भी करना है कि हाइपरग्लाइसीमिया दोबारा हो तो नहीं रहा, तो हम उसकी HbA1c 3rd मंथ में रिपीट कराते रहेंगे एवरी 3 मंथ, एंड इवन एट द एंड ऑफ फर्स्ट ट्रिमेस्टर के बाद भी हम चेक करवाएंगे कितनी उसकी HbA1c आई है। ओके, अब हम Insulin was found fasting with glucose of more than 100 mg, but is which of the following medication was not prescribed to her? I don't know, either it's A or D, because insulin is prescribed, metformin can be prescribed, but I have no idea what laboride and torbutamide. Either it's D or E. I think I will go with A. Sure, it's D. Torbutamide. Torbutamide is used for the treatment of gestational diabetes. Not used. First line glycemic control agents in pregnancy are insulin, glargine, and metformin. Nice. First generation sulfonylureas such as torbutamide and metclopramide can cause heterogeneity, neonatal hypoglycemia, and fetal hyperinsulinemia. Right, this I should write down. Because it doesn't not cross. Placenta, whereas metformin does cross placenta. Okay, and if you're asking about what are the first generation sulfonylureas, write it here that first generation sulfonyl ureas such as torbutamide and chlorpropramide. They can cause heterogeneity. hypoglycemia. If you are talking about the first generation sulfonamide variants such as tolbutamide and chlorpropamide, it causes pterogenicity, that is fetal hypoglycemia and fetal hyperinsulinemia. If you are talking about the first line glycemic control agents in pregnancy, they are the insulin, glyburide and metformin. Next question. A preemie at 30 gestation is immediate preterm labor contraction. She was diagnosed with a gestational diabetes on screening. Which of the following tocolytic drugs should be avoided in her? Tocolytic drug. Even if you want to give, you can give nifedipine. But tocolytics are contraindicated in a diabetic mother. I'm not sure about this answer. Terbutaline. So these are the drugs which are not given, that is Etrodin, terbutaline or salbutamol. These should not be given, as they can cause hyperglycemia. Beta agonists lead to hyperglycemia. Beta mimetic drugs. According to American College of Obstetrician, macrosomia is defined as fetal birth weight of more than 4.5. I think so. Yes, macrosomia is more than 4.5. Gestation level, which of the following is an independent and substantial risk factor for macrosomia? That is BMI. In gestational diabetes mellitus, which of the following is an independent and substantial risk factor for macrosomia? BMI. चांसेस पढ़े भी दिए मैंने। मुझे लगता है मैंने 40% पढ़ा शायद। 50%, दैट्स ह्यूज। 50% चांसेस हैं कि वो पक्का आगे जाके डायबिटिक होगी। The least likely to occur is tetralogy of Fallot. Ventricular septal defect होगा, ट्रांसवर्जन ऑफ TGA, ये दोनों भी हो सकते हैं, या तो A है या तो ये है, पर मैंने पढ़ा था कि tetralogy of Fallot is least likely to occur. BSG मोस्ट कॉमन है, उसके बाद TGA है। Less than 8. Serum calcium less than 8 is hypocalcemia in a newborn baby. प्री-जेस्टेशनल डायबिटीज़, क्योंकि जेस्टेशनल डायबिटीज़ मेलिटस में नहीं होता है। प्री-जेस्टेशनल डायबिटीज़ मेलिटस होगा, उसी कारण कंजेनिटल डिफेक्ट्स होते हैं। Which of the following may be the most effective contraceptive for women with hypertension and a history of gestational diabetes mellitus? I heard it would be progesterone. Shit, it would be IUD. और फिर पिछले अनीमिया वाले में होगा. Let me recall it. Best contraceptive. उसमें ये था कि प्रोजेस्टेरोन जो सा होता है वो प्रिवेंट करता है उसको, किस चीज़ को, पता नहीं, प्रोजेस्टेरोन किसी चीज़ को प्रिवेंट करता है। पिछले दिन से एमसीक्यूज किया उसमें था वो। तो अगर डायबिटीज़ है तो डायबिटिक में, बट डायबिटिक फीमेल है तो उसको कौन सी बोलोगे? डायबिटिक फीमेल है तो उसको बोलोगे कि ऐसा करो तुम आईयूडी रख लो, आईयूडी इज़ बेस्ट। आईयूडी आर मोस्ट इफेक्टिव कॉन्ट्रासेप्टिव चॉइस इन पेशेंट विद जेस्टेशन, डायबिटीज मेलिटस एंड हाइपरटेंशन। क्योंकि अगर हम माल कॉन्ट्रासेप्टिव लेते हैं तो उसमें कार्डियोवास्कुलर इफेक्ट्स आ सकते हैं, पर इनमें नहीं आते हैं। ओके ये भी लिख लेते हैं। Best contraceptive device. IUD because no risk of CVS. और अगर हम बंदे को डायबिटीज़ है ना, अगर बंदे को हाइपरटेंशन है, अगर बंदे को डिसलिपिडीमिया है, अगर बंदे को ओबेसिटी है, तो IUD इज बेस्ट. Don't prefer hormonal. Okay, done. Let me check my marks. Nice. Didn't expect it. 83 percentile. So done with this, done with that. 27 is also done. Anemia and pregnancy, have I done that? sickle cell anemia and deficiency anemia. I think I've done. Let me check it. Yeah, I've done it. So I didn't make it public. Why is it going public? I didn't make it public. I was just thinking about making it public, but I didn't made it. Literally, I swear I didn't did that. ओहो मेरी चुप्पी हो गई यार। ओके चलिए। नेट थोड़ा स्लो चल रहा है। Okay, so we have done this chapter. Now let's move to another chapter. This is an important chapter, that is why I'm thinking of doing it in the morning. Let's do something different. But it is easy, but I think it should be done in the morning because it's a very important chapter. गायनी के टॉपिक बड़े तगड़े तगड़े हैं, मतलब सारे ही एक से एक इम्पोर्टेंट अच्छे वाले टॉपिक हैं कि पूछ सकते हैं कि भाई अब क्या हो गया, अब क्या हो गया। MCQs ही करते हैं क्योंकि सारे टॉपिक्स इम्पोर्टेंट हैं एंड आई थिंक ये सारे कल करने चाहिए। आज मैंने बस इतना ही किया। आई थिंक अबॉर्शन और MTP कर लेते हैं 135। Pregnancy loss that is occurring before the period of pregnancy loss that is occurring before the period of viability, that is pregnancy loss that is occurring at the less than 20 weeks of gestation. Period of viability होती है 20 weeks, ठीक है। fetus क्या weight है 20 weeks होता है around 300 grams. Pregnancy loss with the weight of fetus less than 500 grams at 24 weeks of pregnancy. This is the WHO definition. If we using the ultrasound criteria, if we see if there is abortion, it could be two type of abortion. It could be blighted ovum or it could be missed abortion. What is a blighted ovum? That there is no gestation. If gestation sac is visible but yolk sac is not visible, that means there is no fetal pole, no cardiac activity, right? Just in missed abortion, gestational sac is there, yolk sac is there, tissue is identified but there is no cardiac activity. How will you ultrasound sound पे you will detect that it is a blighted ovum and mean sac diameter is more than 25 mm, then it is a blighted ovum. There is no yolk sac, no fetal pole, no cardiac activity. And when you see the crown rump length is more than 7 mm and there is gestational sac, there is yolk sac, but there is no cardiac activity, then you will say it is a missed abortion. Abortion can be of further spontaneous, induced or recurrent. If it is spontaneous, it is isolated. If it is induced, that is because of MTP. And if it is recurrent, that is more than 3 pregnancy losses has been there, and investigation should begin after 2 abortions. If we go for spontaneous abortion, that most common cause could be chromosomal abnormality, that it could not develop properly. Like most common chromosomal abnormality would develop in the first trimester, and 50% abortion would occur there, and it could be a germplasm defect, and 35% death occur in second trimester. They are unable to grow properly. And most common time of spontaneous abortion, if it has to occur, it occurs in less than 8 weeks. That means in mostly it is seen around you'll say first month and 8 weeks Okay, first second month, less than 8 weeks. Most common chromosomal abnormality to detect for abortion. Best answer is aneuploidy. So aneuploidy is the most common chromosomal defect for abortion. And if you have to talk about most lethal trisomy is there is trisomy 16, and the most viable trisomy is trisomy 21. Even people do live many years with Down syndrome, that is trisomy 21. मेरा फाइनल वाइवा वाले दिन डाउन सिंड्रोम आया था. मुझे इतनी सुंदर और ब्यूटीफुल गर्ल थी वो डाउन सिंड्रोम थी, एंड आई वाज लाइक मंगोलियन फीचर्स और वो सब उसमें था. बट आई वाज लाइक, एंड द मदर इज ऑल्सो नॉट नोइंग कि उसको डाउन सिंड्रोम है. मतलब what is actually a Down syndrome, will have to she would actually come to know about it in few years. It was just a baby. Okay. If we talk about the most lethal trisomy 16 and most viable trisomy 21. Most common sex chromosome abnormality is Klinefelter syndrome, and the second most common sex chromosomal abnormality is Turner. Most common sex chromosomal abnormality is Klinefelter syndrome. Wow. 1 in 1,000 people are born with Klinefelter syndrome, and second most common sex chromosome abnormality is Turner syndrome. out. The most common is Klinefelter, second most common is Turner. Most common risk factor for abortion is maternal age. Second best is previous history of abortion. Previous history of first abortion तो ये हो जाएगा second abortion में. Infection can lead to single episode of abortion. Maximum time of abortion is first trimester less than 8 weeks. If you're talking about the recurrent abortion, that could be a uterine cause, which is the most common cause. मतलब यूट्रस के कोई cause होता है, जैसे यूट्राइन की कोई ना कोई malformation होती है जिसके कारण abortion हो जाता है. रिकरेंट में बार बार हो रहा है जिसमें वो डेवलप हो रहा है, यूट्रस की कोई ना कोई गलती है इसके कारण, या फिर कोई एक्वायर्ड कॉज होगा जैसे सर्वाइकल इनकम्पिटेंस, फाइब्रॉइड या एंडोमेट्रियल पॉलिप. मतलब कुछ ना कुछ यूट्राइन कॉज होगा अगर रिकरेंट दोबारा हो रहा है. ठीक है. और ये क्या कैसे कर सकते हैं कि जो सा अगर यूट्राइन कॉज होगा ना तो यूजली तुम देखोगे सेकेंड ट्राइमेस्टर में ही होगा. अगर तो कोई यूट्राइन मॉलफॉर्मेशन है, कंजेनिटल है, या फिर क्या हो सकता है कि पॉलिप आ गया, फाइब्रॉइड आ गया, ये सर्वाइकल इनकॉम्पिटेंस जो मोस्ट कॉमन कॉज होती है. और यहाँ पे जो सा रिकरेंट अबॉर्शन होता है वो सेकेंड ट्राइमेस्टर में ही होता है. रिकरेंट प्रेगनेंसी जब हम इन्वेस्टिगेशन करेंगे तो हमें पता लगेगा कि यूट्राइन कॉज आ गया. अगर तो इन्वेस्टिगेशन हम कैसे करेंगे, मान लो अगर वो बेबी प्रेगनेंट है तो ट्रांसफ्यूजन सोनोग्राफी करेंगे. उससे हमें पता लग जाएगा कि रिकरेंट कॉजेज का कारण है सर्वाइकल इनकम्पिटेंसी. पर अगर वो नहीं प्रेग्नेंट और हमें जस्ट स्क्रीनिंग टेस्ट करनी है तो देखने के लिए कि बार बार क्यों रिकरेंट अबॉर्शन हो रहे हैं, तो हम हिस्टेरोसेल्पिंजोग्राफी कर सकते हैं, सेलाइन इन्फ्यूजन सोनोग्राफी कर सकते हैं, हिस्टेरोस्कोपी कर सकते हैं, लेप्रोस्कोपी कर सकते हैं. तो hysterosalpingography, saline infusion sonography, hysteroscopy and laparoscopy. What are the causes for recurrent abortion? Causes for recurrent abortion is antiphospholipid antibody syndrome, that is 5 to 15%. Investigations चाहिए antibody, that is lupus anticoagulant, anticardiolipin antibodies, anti-beta 2 microglobulin, chromosomal abnormality, that is balanced translocation of chromosomes, and investigation is karyotyping. If you're going for causes for recurrent abortion, then we'll go for antiphospholipid antibody syndrome, that is the second most cause, and investigation में आएगा antibodies जैसे lupus anticoagulant, anticardiolipin antibody, anti-beta 2 microglobulin antibody. थर्ड कॉज होगा माइक्रोसोमल अबनॉर्मैलिटी, जैसे बैलेंस ट्रांसलोकेशन ऑफ क्रोमोसोम्स होता है. बैलेंस ट्रांसलोकेशन ऑफ क्रोमोसोम्स होता है, इन्वेस्टिगेशन होती है कैरियोटाइपिंग, ठीक है। हाइपोथायरॉयडिज्म ये भी एक कॉज है जो कि TSH लेवल डिक्रीज हो जाते हैं। Probable cause of recurrent pregnancy loss, diabetes, increased prolactin level and luteal phase defect. Pregnant females, progesterone level less than 5 nanogram. Infections never lead to recurrent pregnancy loss except syphilis, which is also known as Kasowitz law. As number of pregnancy losses increases, period at which the pregnancy end also increases. Syphilis don't lead to only recurrent pregnancy loss. Investigation is VDRL test. Investigation no role in recurrent pregnancy or TORCH. Serum progesterone level. Most common cause of recurrent pregnancy loss is uterine causes. Antiphospholipid and autoimmune diseases have been linked to poor reproductive outcome. 5 to 15% of patients with recurrent pregnancy loss may have antiphospholipid syndrome. Most common cause of immunologic cause for recurrent pregnancy loss is APLA. So what were the causes of recurrent abortion? First is the uterine cause. This is the most common cause in 10 to 15%. What causes it? Congenital causes or the acquired causes. I need to do it. Okay, so first we have very different causes. First of the causes, uterine causes. Then we have the antiphospholipid antibody syndrome causes. Then we have the chromosomal abnormalities. Then we also have the hypothalamus. In uterine causes, we have the congenital and acquired causes. Congenital is most commonly if congenital abnormality of the uterus is present, like septate uterus is present there. And acquired causes are the one which are acquired later on in the life, and these include cervical incompetences there, fibroid is there, endometrial polyp is there, right? And the uterine causes that lead to second semester recurrent pregnancy loss, right? So जो से हमारे spontaneous abortion होंगे ना, वो फर्स्ट वीक less than 8 weeks में most commonly in the first trimester में होंगे. But if you are talking about the recurrent abortion, that would occur in the second trimester only. The pregnancy is growing and ultimately something happened and it could not continue further. So if the patient is most common causes acquired, that is cervical incompetence, and if the patient is pregnant, we can go for ultrasound and we can check transvaginal sonography. But if the patient is not pregnant and we need to know why his previous pregnancy were recurrent abortion cases, so we'll go for hysterectomy, angiography, saline infusion sonography, stereoscopy, laparoscopy. These are the procedures that we can do. And another second cause was antiphospholipid एंटीबॉडी सिंड्रोम. ठीक है, इसकी इन्वेस्टिगेशन क्या है? लूपस एंटीकोगुलेंट, एंटी कार्डियोलिपिन एंटीबॉडी, एंटी बीटा 2 माइक्रोग्लोबुलिन एंटीबॉडी. Then we go to the third cause, that is if there is a chromosomal abnormality. Like in case of chromosomal abnormality, it could be a first trimester abortion also, and in case of chromosomal abnormality, it could be second trimester abortion also. That is resulting in recurrent abortion. Then fourth cause is like hypothalamus, if TSH is very low. Then the most probable cause for recurrent pregnancy loss, that is known as RPL. What is the difference between recurrent abortion and recurrent pregnancy loss? I don't know, but they have separate heading that causes of recurrent pregnancy loss is diabetes, increased prolactin level, and luteus weight defect, where pregnant female progesterone level is less than 5 nanogram. Low progesterone, diabetes, and increased prolactin. अगर prolactin increase हो जाए तब भी प्रोलैक्टिन इंक्रीज हो गया तो, प्रोजेस्टेरोन डिक्रीज हो गया तो, और डायबिटीज़ इंसुलिन इंक्रीज हो गया तो ये चीज़ें हैं जिससे प्रेगनेंसी लॉस हो सकती है. आई थिंक इसका मतलब है कि डेथ हो सकती है, पर अबॉर्शन का मतलब भी तो यही हुआ ना कि वर्टैलिटी उसकी चली गई एंड नाउ द बेबी इज नो मोर अलाइव. ओके, आगे जाते हैं. तो दे हैव अ सेइंग दैट no infection can lead to recurrent pregnancy loss except syphilis, and syphilis, this law is known as Kasowitz law, and as the number of pregnancy increases, the period at which pregnancy end also increases. Okay, so if 10th week, next 11th week, then 12th week. And syphilis does not lead to early recurrent pregnancy loss. syphilis हमेशा लेट प्रेगनेंसी लॉस ही करेगा, मतलब अर्ली फर्स्ट ट्रिमेस्टर वाला में नहीं करेगा. एंड इसकी इन्वेस्टिगेशन इज VDRL टेस्ट. सो investigations, we can go for torch test or we can go for serum progesterone level. Okay, most common cause of recurrent pregnancy loss is uterine causes. that is most of the weekend trend was 10 to 15% as compared to AP. Antiphospholipid syndrome की अगर हम बात करें तो this is a several autoimmune diseases that have been linked to the port obstructed outcome. इम्यूनोलॉजी कॉज की अगर हम बात करें तो इसमें भी APL है.